Good afternoon. My name is Ellen Elam, and I'm a Susan G. Komen board member, and I was also on the planning committee for this event, so thank you all for coming. I'm also the sister of a metastatic cancer patient. So I have been down this path that you all are going on, and I'm excited to be a part of this and hearing all the new research and information that's available. So thank you guys for allowing me to be here and be a part of this too. So this afternoon's session on MBC in the liver and lungs will be held by Dr. Annalise Gonzalez, Pat Jones, and Samantha Dewey, and will be live streamed on KomenHouston.org. Dr. Gonzalez is the medical director of the Memorial Hermann Cancer Center, an associate professor in the Department of Internal Medicine and director of the Division of Oncology at the UT Health McGovern Medical School. Pat is a 25-year breast cancer survivor. Yay. Originally diagnosed with HER2-positive stage 2 breast cancer in 1993. Pat's cancer returned and she was diagnosed with metastatic breast cancer in 2003. And Samantha Dewey was diagnosed with metastatic breast cancer in 2013. She has received chemotherapy, a mastectomy, traditional radiation, reconstructive surgeries, stereotactic radiation, and endocrine therapy. So here's Dr. Gonzalez.
Well, thank you, first of all, for inviting me. And this is my first time doing this talk. So I try to keep it sort of with all the main components, but obviously the point is to discuss and answer any particular questions that any of you might have. So I thought I'd give an overview of these, and then sort of maybe we can talk about specific questions and so in detail. So just some statistics that I know many of you know about the incidence of breast cancer. About 12% is a lifetime risk. And then just the cases of invasive cancer, about 252,000. And then that this is the most common malignancy in women and second cause of cancer death after lung cancer, unfortunately. So I thought I'd like this slide. I was kind of looking around, so, you know, about metastatic breast cancer and just sort of, you know, what might be interesting for people to know. And I thought this was very interesting because me as a physician, I think sometimes we need to be reminded that people have some misconceptions that we might have to make a better job at explaining, you know, when we're seeing patients in the clinic about, you know, what is the reality about breast cancer and the possibility of metastatic disease. So I think, you know, it's important to just sort of mention that 30% of patients who have early stage breast cancer initially can develop eventually metastatic breast cancer. And sort of the statistics of women and men that are living with metastatic breast cancer and the numbers, you know, in the United States. And then the median survival after metastatic breast cancer diagnosis, this is an estimate. Of course, a median means, you know, it's a bell-shaped curve. So we have women who unfortunately don't do well initially because they may have a lot of disease up front. And then we have patients who do very well. And we have all people who are in breast cancer have their patients who are long-term metastatic breast cancer patients that are, you know, long-term survivors. And then there's sort of the middle. And so this is sort of kind of what we see in the statistics. And so I think despite the fact that it's prevalent, you know, some surveys have shown that more than 60% of women say they know little to nothing about metastatic breast cancer, and that 72% believe that is curable in the advanced stages if it's diagnosed early, like right when it's found, you know, if it's diagnosed not necessarily like with significant disease in a lot of organs. And then some people believe that if patients got metastatic breast cancer, it's because they did not take the right treatment or didn't do preventative measures. And we all know that is absolutely not the case. So I thought I'd just show some of these things that statistics that people may not be as aware of. So a little bit about where does breast cancer tend to go. And so I think everybody in this room is familiar with how breast cancer or where breast cancer starts, which tends, is the breast. And then that there are multiple lymph nodes that sort of drain the breast where the breast cancer can go to. And some of this can make a difference in terms of it's a sort of more high risk situation if a breast cancer has gone to some of these particular lymph nodes, like the internal mammary or the supraclavicular or infraclavicular, which are kind of up here, and then the inner part of the chest. And sometimes the axillary ones are a little bit lower risk, and that has to do with how we stage as well. So higher stages, if the lymph nodes that are involved are some of the other ones that I mentioned. And then the places where breast cancer tend to go, which is liver, lung, bone, and then brain, those seem to be the most common ones we see. So how does this happen? And I think this is the question that I get a lot from patients who have had, say, 8 years, 10 years disease-free, and then suddenly now here it comes this new area, and then you do a biopsy and it's actually metastatic, and it's the same cancer that was originally in the breast. And so we don't really know the answer to this precisely, but the sort of theories and the thoughts is that there are cells that escape the primary tumor and that they can circulate in the system. They can lie dormant in other tissues for decades, or sometimes for a couple of years, or sometimes for months. And what leads to the activation of these cells? What leads to this to suddenly blossom and show cancer in other organs? And that part is things that we're not completely sure about. We think that some of it has to do with aggressiveness of cancer. So some cancers being more aggressive then tend to start to grow and replicate a lot faster. The environment. So some environments might be more open to the proliferation of cancer cells. So there's a lot, of course, as you are probably aware of play with the immune system, and that immune system allowing these cells to sort of take seed and grow. And so there is a balance there, and then suddenly this balance is broken, and then these cells start to grow, and then you see patients develop sort of more disease. And that even can occur in the metastatic setting as we know it, that some people have metastatic disease in the bone for many years, and then suddenly something occurs. Maybe what we think is there's mutations over the years, and then you develop a clone of cells that is very resistant, and then that's the one that is more aggressive, more resistant, and starts to cause problems because that's the one that can go then to other places of the body. So let's talk a little bit then primarily on lung metastases. So I just thought I'd do some brief sort of overall how patients tend to present with lung metastases. A lot of the times what we see is patients that are coming with no particular symptoms, and they are found with incidental. So some imaging studies done as part of a treatment follow-up or for another reason. Sometimes on my patients, if we do initial treatment and we had done initial staging and there was something in the lung area or the axilla or something that I want to follow again, I might repeat a CT scan in a few months or so forth, and then you find something on that. Or maybe somebody got a CT of the chest because they were having shortness of breath and they went to the ER and they did a CT of the chest, and boom, they find this incidental. It's like something that was there on the side, because the lungs, obviously we have two, they're kind of large areas, so you would have to have certain amount of disease for it to start to give symptoms. So if it's only a couple of lung nodules, many times patients are completely, without symptoms, feeling very well. Now, when people present with symptoms, then what we see usually is sometimes there can be pain or discomfort kind of in the chest area, non-specific. A lot of times one of the presenting symptoms tends to be shortness of breath, new. Sometimes, they can be wheezing or persistent cough. Persistent cough is also something that we see as a presenting symptom sometimes. And then coughing, so that usually is the cough that goes up with a little bit of shortness of breath, and then occasionally the coughing up blood. That I think is less common as an initial presentation, but can occur sometimes. So imaging tests that are done for the workup of cancer in the lungs. So the CT chest would be one of the most common tests. And then sometimes you might hear or be ordered a PET CT, which sometimes can complement the CT scans. So the CT scans show us the anatomy, shows us lesions. They don't really show us sometimes how active these lesions are, or sometimes if you have something that's relatively small, it could be other things too. So finding a lung nodule doesn't mean that it's cancer. Lung nodules are very common. So if we do CT scans and 10 people who have no history of anything, 4 of them are going to have lung nodules of some sorts. And maybe 5. And then that's just basically something that can be because, we live in Houston and breathe this air, or it can be because we had an infection, allergies, we were smokers, many other reasons. So sometimes PET scans can help make the distinction between something that is an old scar from a previous infection versus something that is cancerous, because as these cells are growing more rapidly, the PET scan uses a sugar-like compound that cancer sort of likes and absorbs. And so those areas are going to look brighter, and then that makes it more likely that it could be cancer. So most of the times, if we have a patient that presents with a lung finding, that be a small nodule or multiple nodules for a bigger area, one of the things we want to do is a biopsy. Obviously, we always want to make sure that we're saying, the right diagnosis, that we're not mistaken, and this is not cancer, for instance, or that this is not another cancer. If somebody, say, has a history of smoking and then had a history of breast cancer and now comes with some lung findings, we want to make sure it's not lung cancer, because this has happened, of course. So how do we do biopsy? So we have either bronchoscopies, which are done by pulmonologists, which are lung doctors. And so that usually entails putting it goes under, tube through the throat. The patient is asleep, and then they go in, and through the trachea, which divides in the bronchus, they can go in with a needle and take samples of masses or areas, or sometimes lymph nodes that are around the sort of breathing pipes, if you will. And so that's usually done for people who have lymph nodes or masses that are very central, so close to the respiratory airways. Other times, the lesions are more distal, so more like peripheral. In that cases, we do a lot through the interventional radiologists. They do use the CAT scan to help them guide to do just basically a needle biopsy that way. And so they do those particularly for lesions that are a little bit more away. And then sometimes there's actually surgical biopsies where there's a removal of the area of concern for testing. And sometimes we do that if it's somebody who's had, say, a long period of interval between the initial diagnosis and it's only one area and it's a small nodule and it's kind of located peripherally. Then sometimes if it looks suspicious, you might as well go in and remove the whole thing. And then it also could be a treatment as such, as well as diagnostic. But usually we don't do that if we are sort of have multiple areas, or if it's a short period in between diagnosis, because we are presuming that we're going to need to do some more sort of systemic treatments that treat everything. So then we do the biopsy, we confirm what kind of cancer this is. And of course, one of the most important things that we do on patients with metastatic cancer, and you may be aware of this, is retest these receptors, because about 15% of the times they can have changed, from being a tumor that was estrogen receptor positive to negative, or vice versa, and same thing with the HER2. And this might open or close options of treatment for us, so we do that. So what are the most common treatments for lung metastases? I would say the most common treatments are systemic medications. So these are usually IV medications or oral medications that are going to get throughout the entire body. The reason for that is lung metastases are what we call visceral metastases. So they're in sort of organs that have a lot of blood supply, and that most of the reason why these occurred is through kind of blood seeding. So you really want to make sure that you're treating the entire body, because there's very high likelihood that there could be some more cells in the bloodstream. So you don't want to get just the lung areas, but also you want to treat the rest of the body, okay? So those could be either chemotherapy, hormonal therapy, which is endocrine therapy, pills, and or targeted therapies that can enhance these other regimens. And so I really didn't spend too much time on this, because I think that this is more depending on what type of cancer a patient might have, what systemic treatment is appropriate. But I'm happy to answer any questions that people might have about this after we finish the presentation. I decided to spend a little bit more time on some of what the specific treatments for lung cancer, so some of the local treatments that can be recommended under certain circumstances. So we talked a little bit about surgery. So usually we limit that to patients that have only one area of metastases, that a lot of times we want to have some evidence between disease, from time to disease initially to this, because then that makes more likely the fact that maybe that's the only spot, that if you remove that spot, then you might have more time that patient doesn't have, again, the cancer showing up. And occasionally we do it too on patients who present initially with the breast cancer and one lung area. So we've done that too for those patients, either surgery or the other treatment that we have under here, stereotactic radiation, right? So that is basically high doses of radiation to a particular area, usually given over 5 days, and it can be very useful for patients that have, say, one or two areas. Again, we're not going to do that if there's several areas, because it's not really the appropriate treatment, because you would be kind of, in some ways, not treating the whole issue, because more than likely this person is going to have some disease besides what you're seeing in the scan. So you want to do systemic treatments, but it can be an adjunct, or it can be that, say you gave systemic treatment, you got a great response, and all that's left is 1 or 2 areas. Well, then we might want to consolidate, particularly with the stereotactic radiation. So that also minimizes exposure to the healthy tissue nearby, as opposed to the regular radiation where you get kind of a little bit more broad exposure. So I just put some images. I mean, I know that patients usually like to see some of these things to kind of understand what does it look like, what does it mean. So this is just an X-ray, but here you can see the heart in the middle, and then you see, the lungs are the 2 areas that are gray, and then this area here are the ribs. Then you see these areas there. So that would be what lung metastases could look like. So there's just these areas, these little lesions there, or nodules, and depending on the size, they can be very small, they can be larger. And then, for instance, this person here would really benefit from systemic treatment, because you already have multiple areas. So you really want to treat with some systemic therapy, whatever is the best one for that particular patient, subtype of breast cancer. But then, for instance, you have this one where you only have one spot. You see it here, right? So you have one spot. So maybe that would be the person where we would suggest doing something like the stereotactic radiation, or something, a little bit sort of more local therapy, okay? Most of the times, though, even if we do local therapy, we also would consolidate with systemic therapy. Or like I said, sometimes we give the systemic therapy first, make sure the patient is stable, nothing else is showing up. Then we go back and say, okay, this patient's been stable on the systemic therapy for a while, let's consolidate this with stereotactic. So it really depends on each individual case. I also wanted to mention, because sometimes people present with different things, what is pleural metastases and pleural effusion. So breast cancer cells can collect in the fluid that surrounds the lungs. So all of us have fluid in between our lungs and the chest wall or the ribs, right? Because every time we breathe, if you see somebody breathing, you can see the chest is moving. And so the lungs are going up and down a little bit in that cage of the bones and muscle and all of that. So there's always a little bit of fluid there to kind of keep that area sort of lubricated, so it's not like just, right? So that would be the normal situation. But unfortunately, sometimes breast cancer goes into that area, which is called the pleura, which is the membrane that kind of covers the lungs. And those are the ones that are actually producing that little bit of fluid all the time. So when those membranes are involved by cancer cells, then those cancer cells start to behave abnormally. And so what do? They start making fluid, because that's what the cells normally would do, but in an abnormal fashion. So they make a lot of this fluid. And so there's fluid, and that fluid starts to push, and this is a closed space. So the lung can kind of collapse inside, and you have this pocket of fluid. So for that type of thing, we do what is called thoracentesis, which is basically a needle is inserted in that space, and then fluid is removed. Sometimes, if there's a lot of fluid being produced, we will actually place a drainage catheter that stays there, and the fluid is drained, daily by the patient, and therefore they can breathe better, because you can imagine that as that compresses the lung, the patients usually present with trouble breathing. So this would be a picture of that. So you can see that lung here, how it sort of is pushed by that fluid. Where on this side, the lung goes all the way down here. So the fluid normally should be a little bit just between this and this. So that's what a pleural effusion looks like. And so we can just drain it, or we can put a catheter. Many times for this, when we see these patients, again, if this usually is we recommend to approach this with systemic therapy, because actually it can work very well. And I've had several patients that I've treated initially with chemotherapy or with oral treatments, and you actually sometimes have to put a drain, because we are having to do these punctures to draining very often. And then usually after the treatments start to work, this area kind of dries out, and then you can actually remove the drain. And some of these patients actually can do well. So it doesn't mean that because somebody presents acutely very sick, that means that you can't get the problem better. Although sometimes, of course, it's not going to be the case. But of course, we are going to always try our best. So I was going to spend a little bit on liver metastases. So liver metastases, again, can present initially with no symptoms. For the same reason, the liver is a large organ. It's a very, works very well. Even with smaller areas of it, you can still have a functional liver because it's a vital organ. Therefore, you have to have quite a bit of disease initially for patients who have symptoms. So again, sometimes patients present with just mild elevation of the liver function tests. So these are tests that we're normally testing a lot on the blood work. So if we see that, that's usually a red flag for us to look at the liver, make sure there's no cancer in the liver. And then unfortunately, sometimes we will find that there are some liver lesions. And so when patients present with symptoms, it tends to be pain or discomfort in the midsection or towards the right side. A lot of times it's more nonspecific, like fatigue, weakness, weight loss, poor appetite. Occasionally there can be, these low-grade fevers, and it's just because the cancer is kind of creating these fevers, or a feeling of bloating or swelling, and we'll talk a little bit about that one specifically. And sometimes there can be some swelling in the legs, or sometimes patients can present, yellow with what the people call jaundice, which is obviously more concerning because it usually occurs when the liver is not working properly. So what kind of imaging do we do to detect liver metastases? So this include, MRIs of the abdomen, CT scans. Sometimes you can do just a plain ultrasound, and that can allow you to see some areas that are concerning. And then, of course, the PET-CT, as I mentioned, can be a adjunct because, again, some liver lesions can be benign. Not all liver lesions are malignant. If we do a CT scan on a lot of us, we would find cysts, which are water-filled lesions that are benign, or things called hemangiomas, which are vascular that are benign as well. So, the PET sometimes can help make that distinction because these will be very bright. So, most of the times for liver metastases, again, with our breast cancer patients, many times liver metastases are not initial presentation. Many times those are things that can happen later on. And so most of the times patients will receive systemic therapy, again, because it's a very vascular organ. Therefore, you need to treat because it's likely that there's some blood sort of burden of cancer as well. And again, the systemic treatment would be depending on what type of breast cancer that patient has. So this is just an example on a CT scan of how liver metastases would look. So you see that liver looks just like a normal grayish color. And then there's some areas that look a little bit whiter. Those are sort of blood vessels in the liver. And so we shouldn't see the areas that are in the arrow, like this little areas here. That's all sort of abnormal looking. And so that would be an example. And that can be as little as, one area, or it can be the whole liver is full with these areas. So very different things, or a big mass. I mean, we see many different presentations, and of course that will sort of determine what kind of therapies can be offered. So there are several local treatments for liver metastases, and some of them can be very effective. Again, I also have treated patients with, say, somebody that presents with a breast cancer originally sort of large and with a lot of lymph nodes, and then we did imaging, we found a liver lesion. So then again, we would probably give that person systemic treatment first, make sure that everything is taken care of. And then if all that is there is just a liver area, well, we go for the liver and we can do some local therapy. And I've had several people who've done kind of very well with that. Again, you can't tell them you're cured because, we don't even tell the patients who have stage 1 breast cancer you're cured 100% because we don't know, right? So those patients do have a risk of the cancer showing up, but I've had several of them that are now going on 10 years free of disease. Now, can I tell that person is never going to come back? I can't. You have to keep following them. But I mean, we have patients who do well with some of these local therapies. So what are these? So there's cryoablation, which uses extreme cold in the tumors. There's things called radiofrequency ablation, which uses the high frequency electrical currents to kind of sort of disturb the cell adhesion of the cancer and therefore kill the cancer that way. RFA can also be done in the lungs, but we don't do it as much as some of the other things I mentioned. Nano knife, which is also, that one is more electrical currents into the tumor cells. And so then that also leads to cell death. The radiofrequency also has a lot of, there's also some heat involved in that to kill the cells. And then the Y90 radioembolization, I've used that a few times for patients that have sort of more disease, because the Y90, they basically go and deliver sort of these high radiation inside the tumors. And so they cannulate the liver and then they give these high doses of radiation in there. So you can do just one side, so one lobe, for instance, if you have somebody who has a lot of disease on the one side, or you can do both. But ideally, I try to do just one side because I want to try to preserve, the liver function as much as possible. And then there's also chemoembolization, which is the same principle, but with chemotherapy. So there are these like beads they tend to call this TACE, and it has like adriamycin little beads, and then they can do the same thing. They cannulate the liver arteries and they deliver the beads right kind of where the tumors are. Sometimes we do surgery, and that would be really, again, for a patient that had just one area. They had maybe a long interval between the first cancer and that presentation, just because this is a more aggressive treatment to do. I mean, liver surgery is not, a simple surgery. So you don't want to do that to somebody and then 3 months later, the cancer's, other places. So you want to try as best you can to give that person the best shot. And hopefully if it's only one area, then that person might have a good shot of removing it, particularly if they were like 10 years before that happened. So I've had a couple patients like that too, who had like breast cancer 10 years later, came back in the liver. We did surgery, and then they had like 10, 12 years disease-free with that intervention. So, but I've had that same experience with the radiofrequency ablation. So nobody has really compared specifically these local treatments because some of them are newer than, say, surgery. But surgery might be the one that people think, well, that's the most definitive, but we don't know for sure. So I think surgery for really specific cases, and the other ones are probably very good options too. And like I mentioned, the transarterial chemoembolization, people call that TACE, and it's local chemotherapy that delivers microbeads filled with chemotherapy medication directly into the liver tumors. This is just a little picture. I figured I'd just show you one of these examples. And so they basically cannulate with a catheter and then go into the liver artery, and then to administer the tumor inside the chemotherapy inside where the tumor is. And it has a lot less toxicity than, say, systemic treatment because it's given localized. I mean, it doesn't have zero toxicity. Sometimes people have a little pain after the procedure. Sometimes they have to stay overnight because of that. Usually we don't see a lot of elevation of the liver function test, but obviously that's all something that the patients need to be advised that could happen. And so they check their liver functions, and then we see them in the clinic pretty close to the procedure to make sure that there's no changes on that. And sometimes if there's an elevation, then they'll, come back down. So I think that's all I had put together because I didn't want to talk too long. Oh, I'm sorry. I have this last one was on the same process we talked about in the lungs can occur in the abdomen. So sometimes patients present with what is called ascites, which is fluid in the belly. And then some people are wondering, well, why is your belly so distended? When the patients might come with bloating in those cases. And that is sort of a similar principle than the pleural effusion in the lungs, which is basically we all have inside our belly, there's a little bit of fluid there so that the bowels are not like rubbing against each other. So there's a lining or a membrane that kind of covers all these abdominal organs sort of right under the muscles of the abdomen. So that membrane is called the peritoneum, and that membrane is producing a little bit of fluid all the time. So again, sometimes the breast cancer involves that area. And so if you see on this picture, like this shouldn't be like that. It should be just all, and we shouldn't have this right here. This is actually fluid. So the white part is kind of the bowel. Normally what you would see is sort of some of those white areas like that. And then the rest would be a little bit of dark black. This gray area here, that's all fluid. And then where the arrows are, that's just infiltration of that peritoneum, or some people call that omentum tube, which is another way of calling it. So when that occurs is when we see ascites. And so ascites can be treated in a similar fashion as the pleural effusion. So basically you can just put a needle and drain the fluid, but sometimes it reaccumulates. And so occasionally we have to put a catheter. And again, the usual approach is we put a catheter or we drain it and we start treatment. And hopefully most of the times that will help. And then eventually you can take, if you have to put a drain, you can take the drain off. Not all the times. And of course it depends on the situation. Sometimes if it's more advanced disease presentation where patients have had multiple treatments and now they have ascites, sometimes you can't really take the drain out because you just cannot get the fluid under control. So it varies, but a lot of the times we are able to. So I just brought some other cancer resources in case anybody was interested. I'm sure you guys are getting plenty. And of course the Komen website is great, which is also listed there. And I'm, happy to take questions or have our other people talking. And this is my children, which are which are the reason why I do this every day. Really, we all needed some fire, some fuel that keeps us going. And of course, mine is my family. But I would say always my patients are my other family. I totally think of my patients as my family. I love my patients. So, anyways, thank you, and please.
How's everybody doing? That is so much information. Thank you so much for sharing all that. I feel like, no. I feel like sometimes as patients, we just kind of take for granted, like, what we just hear, what we're told, and take it and go. So first, I'll just tell you a little bit about my story and about my treatment, and then hopefully I can kind of answer any questions you might have about from the patient perspective from treatment. So my story starts off a little different for breast cancer. It didn't start with a lump in the breast. It started with a broken neck. I broke C3. I had just had my second little guy. So I had a 2-year-old and I just had my youngest. And I was nursing him at the time. And so there was nothing strange other than just a very hungry child that I nursed all the time. And I had fallen asleep while I was nursing him one time. And my head was kind of to the side. I'm a PT by trade. I'm married to a physical therapist. He worked on my neck. It felt better. But I was unloading my son from the car, and he likes to fly from like Superman from the car into the house. And when I lifted him up over my head, I heard a crunch, and my arms went numb and weak. And another blessing was I specialize in spinal cord rehab. And I'm like, I'm pretty sure I just broke my neck. So I called 911. We fast forward. We go through all these tests. And I go from going to work that day, picking my kids up from school, just a normal Friday, to at the end of the day, we find out I have cancer in my spine. And then later on, after a lot more tests, we found out it was metastatic cancer. So sometimes I'll be perfectly honest when I hear like early detection is the key and prevention, yada, yada, yada. That wasn't really an option for me. And so sometimes it's frustrating. I have no family history of breast cancer. I'm super healthy. I still work out. I teach dance classes. And so I think it's just the big thing that it's not so much about us doing something wrong as much as us being proactive about what we have in the future. So that's that. So about my treatment, I started off really strong. We did Taxol and FAC in the beginning, which I tolerated really well, but we learned early on that I have very puny neutrophils. So my ANC was always really low. So me and Neupogen are like, we go way back, and I'm sure my insurance company loves me for that. So we started off with that, and actually everything in the bones went to sleep, which was fantastic. And all that I had left was a little bit of tumor left in the left breast. And at that point, I'm sure some of y'all have kind of talked about with your oncologist, is a mastectomy all right? And the horse is out of the barn. It's a big phrase I hear all the time. But just because that was the last that I had left and our goal was to be cancer-free, we went ahead and moved forward with a single mastectomy. And then we also did radiation to some of those bones, particularly C3, because we didn't want it to break again. So anyway, so there was this good time where we actually had everything in the bones asleep, had the mastectomy. And about 6 months later on tamoxifen, my bones started to wake back up again. And so at that point, we realized tamoxifen wasn't for me, and we moved on to letrozole. And letrozole was fantastic. I got a great 23 months out of letrozole. Everything in the bones, some went away, some got smaller, but for the most part, we were stable for all of that time. And then at the end of letrozole, it wasn't like this huge explosion of disease. And I think looking back, if I could talk to the Sam back then, because they had these little bones that would pop up, and I'm like, but they didn't mention this one in the last scan, and they mentioned it in this scan, and he would be like, it's just bone. And it's so funny because now I look back at it and it seems so trivial. at the time. But we had just a little bit more disease every time we went back. And so we decided at that point to go to Ibrance and Faslodex. And so we did Ibrance and Ibrance had just come out on the market. And I was like, it's this miracle drug. It's fantastic. And I have a friend who was on it as a trial, and she's had amazing results. And so I was super excited. Then I only got 4 months on that before it spread to my liver. So it just kind of shows that everybody's cancer is different. You know, it's not one size fits all. And Ibrance is great, and I'm sure it works fantastic for some people, but it just wasn't for me. And so then after Ibrance and Faslodex, then I moved on to Zoletta, which is capecitabine. Some of you may have heard of that. And that worked fantastic on the liver. I think it was about 11 months. 11 months out of that one, and it was really good. I'll talk to you more if y'all have more specific questions about the side effects, because there definitely is a good handful of side effects that come with it. The big thing with it was I was kind of excited because I was able to maintain a good quality of life. It was pills, and I have a 5 and a 7-year-old right now, and so I'm able to, you know, pick them up from school. It's not an IV chemo that keeps you there all day. So there were some pros and cons with that. I think looking back at it, if I could talk to myself back then, my big goal was to get as much medicine in my body as possible, because sometimes I think I just want to kill the cancer. So maybe I wasn't as honest with myself about the side effects with the hand-foot syndrome, because sometimes that would build up a little bit quicker than I thought it would, but I was like, I don't want to stop taking the medicine or them to pull me off of it sooner than I wanted to. And while I was on that, I started having some more issues with my blood work, and that's when we found out that it spread to my bone marrow, which isn't like super common. And it was kind of sneaky because the LOTA also affects some of your counts. So at that point, we decided we had to change. And then when they did I was doing a washout period because I was hoping to get onto a trial, but all my counts plummeted and I didn't qualify for any of the trials. But it was really kind of a blessing, because if I would have gotten on the trial, I might have just gotten booted quicker anyway. So I went from Zolota, had this huge break, and then when we came back to do scans before I started IV chemo again, we found out that it spread to my lung. So then I have been on Abraxane, which Abraxane is a sister drug to Taxol, which worked very well for me in the beginning. Abraxane is just like Taxol, but it's in a protein carrier, so you can tolerate it for a longer period of time. And so I have been on that bad boy for 7 months and every week, which, you know, like it's not so much that there was like one huge side effect. I mean, obviously like losing hair and eyebrows and eyelashes aren't fun. But over time, like the big ones are like losing like fingernails and loss of taste and that kind of stuff that just kind of build up. And it's been working. My bone marrow is doing great, liver's doing great, lungs doing great. But we ran into this other problem, which was in the back of my mind, was that the chemo just got too toxic. Because then my liver numbers started going up, not because of the cancer, it seems to be getting smaller. It's just that my liver numbers are going up because I have so much poison running through my system. So I'm actually taking a break off of it right now. I'm kind of in a little bit of purgatory treatment, our favorite place, right? Like the waiting place. But what we're looking at now is I'll possibly do exemestane everolimus, or I'm looking at a trial. If that works out, we'll see whatever is meant to be there. But my big thing is, I think as long as you're just always, you know, staying educated, I feel like sometimes the hardest part is, you know, just being told what to do and you don't always know what's the best. So trying your best to stay up with all the research. And we are so blessed to be in a great city with so many resources and great doctors and great communities. I mean, just looking around in this room, you obviously all have a desire to be educated about this. And so just having that drive alone is going to help you do really well in your treatment journey. So that's my story. But if y'all have any questions specifically about treatment or anything like that, I'd be glad to answer. Yeah, thanks. Questions? So I think the big thing for me is finding things that bring me a lot of joy. So like I mentioned, I love to teach dance. So I teach dance to little kids, and then I also dance with some adult groups. And so I think that's kind of twofold. That makes me really happy, but it's also a form of exercise. And I'm, also a physical therapist. So I really feel like sometimes exercise is kind of downgraded. I felt like in the beginning, especially when I broke my neck, everybody was like, be very careful, don't pick up anything, and even coming from my oncologist, where I feel it, and sometimes I think it's kind of counterintuitive because they were like, you're getting chemo, we don't want this poison like going through your system. I'm like, don't we want it everywhere in my system? And what a better way to do that than taking a brisk walk or riding a bike at the gym. So I think as long as you stay really active, that gives you one thing to hold on to. I'm sure most of you know the feeling like there's so much you can't control, and it's really frustrating. But the one thing for me that I could control was my activity levels. So if it's playing flag football in the backyard or, riding a bike at the gym, just having that little thing that you can control. It may be really small, but it's one thing that makes you feel a lot happier. So, anything else? Any Salota questions? I feel like Salota always has a lot of questions. No? Well, if not, if y'all have any other specific questions, I'll be around after too.
Thank you so much. Wow, what a difference from when you first got diagnosed and when I did in '93. I feel like a dinosaur over here. And just briefly, because I've talked earlier, I say it all the time, I had no idea that what metastasized was. It wasn't talked about. My doctor didn't explain it to me. I went from 93 having breast cancer. I heard the word estrogen positive. I said, okay. And I said, okay, so you got to remove my breast. And by me being real naive, and I guess I said, I'm not waking up lopsided. So I immediately had the transplant, the reconstruction surgery, had 6 rounds of chemo, went on Arimidex for 5 years. I take that back to tamoxifen at first. Arimidex, immediately after the 5 years, I was being cancer-free. I went back for a routine scan. In that scan, I found out that the radiologist failed to give the report to my physician. Now, I went back the next year. A friend of mine's worked there, and before HIPAA was really popular, she called me and said that something was not given to my physician and that I should check in with her, and she had seen my report. It found out that I had a spot on my lungs. So it took them a whole year when they first saw that. So by the time the doctor got in touch with me, it had grown. I remember in the room, they did a biopsy. My doctor came in the room, and she was just in tears and all distraught. And I'm looking at her like, are you okay? What's wrong with you? And she said, oh, I'm so sorry to tell you your cancer returned. I said, my cancer returned? I said, okay, so what are we gonna do? I had the theory, okay, so you got rid of the first one with the surgery. So, okay, so you're going to, where is it? It's in your lung. I said, okay, so you're going to take part of my lung out and, we're going to do the little thing again and it's going to be fine. Well, no, we can't do surgery. Okay. So we went through the chemo again. I kind of changed institutions and doctors after that because I kind of felt like I had been just put in a system and got lost in that system. So I thank God I had good insurance at the time, which is one of the concerns I have, that for women who don't have good insurance. And what do you do then? And I guess that's why I got into being advocacy so much. But what happens to those that not covered? We already have a critical illness, and then how do you get treatment? And I'm so grateful that we have things like this, that there are resources. Grab them, talk to people, because I've talked to women that they won't go because there's nowhere to go. They don't know where to go. So like I said, I was blessed that I had good insurance. I got treated. I went to a private doctor who I'm still with today. And even now, every 3 weeks, I go on Herceptin, and it's been working for me. I also find that I do have small fragments tissue in my abdomen. But again, all I heard was my cancer had spreaded. Did not know what that word metastasize meant until I got involved with Susan G. Komen. And this M word came about. I'm like, so that's what that is. That's what it is. And because I couldn't understand why it was still called breast cancer. I said, well, no, I have lung cancer. So being ignorant, education is so vital, that education, so I'm coming from behind, and I'm so glad to hear someone's story, and they're telling their story. I Googled, and Google is a dangerous thing sometimes because you get so many stories and you're bombarded with so many things. Well, okay, they got hormone therapy, and now they're saying there's a cure for cancer and all this insane stuff, and we're all individuals. We're all different. Cancer is not just one thing. So I had to get to know Pat first and who she was, what my body did. It was okay. I'm finding out it's okay to ask questions to my physician. They stay abreast of a lot of things, but they have a lot of things too. So I look and I ask questions. I said, well, I read this. What do you know about this? I'm going to bring back some things when I go back Wednesday to my doctor and say, well, this is what I learned. What have you heard? Are you studying this or this research? I've even brought magazines to her and asked questions. So my journey is so different, and it is a journey. And each day is different. I have wonderful days. I have horrible days. But I embrace each day that I have. My breathing, I can't run. I love to walk, but I'm finding out because my breathing, and my friends tell me, oh, you're breathing real heavy and hard. I say, I am. Some things I don't notice, and other people tell me, so I listen to what other people are telling me. I get involved with other women. Girl, this happening to you. I'm on this Arimidex, and I already going through menopause, so now I'm having personal summers. Is it the menopause? Is it the Arimidex, or what? So I ask questions. I reach out. I stay positive. Even when I'm having a bad day, I allow myself to have that. But I stay positive because I'm focusing on right now. Right now. I mean, I think we are all miracles because we still in this room. So everybody ought to give themselves a hand because everybody in here is a miracle. We are miracles. We're still here. We're talking. And our biggest weapon is our voice. My biggest weapon is my voice. It's to reach out, to not be afraid. The first thing when I told my family, my husband, bless his heart, he goes with me every 3 weeks to treatment. And he'll hear somebody ring the bell. And he says, well, when are you going to ring the bell? I'm like, darling, you still don't get it. I said, okay, I ring my bell every day. Every time I walk out Dick Slayton Cancer Center, I'm ringing my bell. Every 3 weeks when I come back in, I'm ringing my bell. It's different. We are different. We are special, but we are, I like this word they say, triumph. We are trying. I heard people talk about being a fighter, but I don't think I'm a fighter. I think I'm in victory. because I have today. And that's what I focus on today. That's what keeps me going. That's what keeps me going, to be Pat. Not an MBC, but just to be Pat, who I am. And I share that. If, like I said, you need to cry. If I'm afraid, I'm scared. When I first went in, my girlfriend had to go with me and hold my hand because I don't want no needle. I mean, I was just terrified. So I spoke out and I took somebody with me. Most of the times they don't let you go back when you get biopsies or treatment. My girlfriend said, oh, she's a mental patient and I have to go with her to make sure. I'm serious. I am serious. And I have to go with her and make sure she gets back. I mean, whatever it takes. Whatever it takes. But I'm still here. We're still here. So I feel like enjoy the day. Enjoy the moment. Live in the moment. That's my story. That's my journey. That's what gets me through. And everybody is different. Everybody is different. Hers is exercise. Yours might be reading. Yours might be playing with the grandkids. Yours might be talking to somebody else. But I had to get out of that darkness, because I did. At the first moment, I sit in a dark room and everybody was on board, and you need to this treatment, you need to do this, you need to do this. And I heard all these little voices. And my sister called me on the phone, and she said 3 words. You always talk to somebody. Where's your faith? That was like a slap in the face, woke me up. And that's what it took for me. And immediately I got out of self, and I redefined myself. So that's what I have to say. If we have any encouragement, and we're here. That's it. We're here. And we're beautiful. We accept yourself for where you are. And that's all I have. Anybody have any questions? That's how I get through the day. No questions? No questions, right? No questions, right? No, really. Does anyone have any questions? Yes. Be there. Be there. Just listen. For me, it was listening. I mean, sometimes you don't have to say a word. Because I hate when people used to tell me, this too will pass. I want to slap somebody when they tell me this too will pass. It is, no, you need to go through it. Walk through it. It changes. Nothing is going to stay the same. The only thing that changes is what? Change. So all you can do is be there for someone. My sister was just there for me. I lived with my sister-in-law at the time, my husband and I can still vision that. I was sitting in that room, all the lights off, and I was just sitting there. I was enjoying my little pity party, and I couldn't invite nobody. It's okay for them to have a pity party. Everybody processes differently. Let her have a pity party, but be there. If it's just having somebody close to you, to feel a hug, you may just have to hold and hug her, and that's what it was for me. And eventually, it is there. Denial is always, we're grieving. It's a grieving process. You're grieving something, and it's all like all the 7 stages of grieving. I went through the denial, all the emotions, everything. And the final stage was acceptance, accepting it. So just be her friend. Yes, ma'am. A support group. Mm-hmm. Mm-hmm. Yeah. Good, good. Yeah, I am with the reconstructions of survivor, and that is, I don't know where you've been unless I walk through your shoes, you know. So somebody's walking that same pathway, and they see that how many years it's been? You did what? You know, that's how we give hope to each other. So thank you for bringing that up. That is true. Anyone else? Thank you, Vince. Thank you so much for giving me this opportunity.
Project well. So I think the okay, so in terms of the fluid and the lung, I mean, sometimes when patients have that, if the fluid is getting sort of more, where you're really having more of that pressure, sometimes there's sort of on that side where the area is, there's actually some discomfort, some pain, and then there's also the feeling on the lung of this pressure. But a lot of it is shortness of breath. It really is just shortness of breath. And I think with the exercise and so forth, it's hard to know what is what. I think a lot of it is tolerance to exercise. So if somebody has been able to do certain things for a while, and that's kind of their usual stamina, and then you see sort of significant change on that, then particularly if it's like a rapid change in terms of, I was able to do this 3 days ago, and now it's really different, then that usually is more about the fluid accumulating. I think that the lung disease, it's really, each case is different. So if it's just lung nodules, I think in general we have a lot less symptoms from the lung disease. It's more when we have sort of a lot of disease in the lung that then we start having more of the breathing issues and more of things like coughing and things like that. And then the stress also kind of exacerbates the asthma symptoms too, I think, sometimes. Yes. So that's a very good question. I'm sorry, what did you say? Mm-hmm. So I think on the ovary removal, that's a question that I get, with certain frequency, and I think that there's two sort of groups of patients. The real young patients with breast cancer that have sort of estrogen receptor positive breast cancer. So usually women under 35. I think that's a group where you can discuss removing the ovaries in the initial diagnosis of breast cancer. Not so much metastatic disease, usually more initial diagnosis. And again, it depends on what their plans are, life wise. Do they have children already? Have they not? I mean, all that obviously would play a role. But that's the group where I look at considering removing the ovaries is in the really young women. For women who are older, it doesn't appear that removing the ovaries is very useful. And then in terms of patients now with metastatic breast cancer, it doesn't appear that removing the ovaries helps that much, because we also have medications that you can suppress the ovaries. There's injections of Lupron, Zoladex, those will suppress the ovaries. And so you don't necessarily have to remove the ovaries, have a surgery. Now, the other group is the BRCA mutation groups. And I think that's why a lot of people started talking about removing the ovaries, right? For patients who do have a mutation that increases risk of breast cancer and ovarian cancer, then that's a different story. Of those patients, we do recommend them to remove their ovaries kind of at any age when they're diagnosed with breast cancer, because the chances of developing ovarian cancer. Sometimes we remove the ovaries on patients who develop metastases in the ovaries. I have a patient who had primarily bone disease for many years, was doing very well with the endocrine therapy and so forth, and then suddenly developed an ovarian area. And we removed it, and it was actually metastatic breast cancer. It wasn't ovarian cancer, it was a metastatic breast cancer deposit. But the thing with the cancers is that now that, of course, now we're seeing also patients that are living longer with the metastatic breast cancer. So then you start seeing things that are less common because people are doing so much better with these treatments. So then sometimes you get a little bit more sort of atypical or different places where cancer might go. And so we're doing more things sometimes. Like this person's had breast cancer, I think, for like 8 or 9 years, but primarily in the bone, very well controlled. So that person, yes, I'm going to remove that lesion because I think that she has another chance of having another period free of disease. So that's why, that we still have to look at each individual. I'm not sure I'm understanding your question. So you mean, oh, I see what you're saying. That's a very good question too. And so some of that has to do with the effectiveness of the treatment, as you're mentioning. So, and some of that, of course, will be determined by the type of breast cancer it is, how sensitive it is to the treatments, and again, the where the cancer is located. Because some cancers are located in places where they're giving more trouble than others. And so a lot of the times, for instance, with the pleural effusion or the ascites or even the lung disease, if that's presenting symptoms and you're starting a treatment, if the treatment works, patients can go pretty back to pretty functional. Mm-hmm. Now, if the treatments are not working, then you might not see that, unfortunately, yes. Well, again, thank you so much for this opportunity and for having me. Thank you. Thank you. Like, you know, like a